today's talk is on ECMO at Peripheral. This is a talk that I give to the anaesthetists as well. I've cut out some of the echo slides because that's not so specific to ICU, but there is some emphasis on the echo training. In terms of what is ECMO, you do need to know what the acronyms stand. As with most aspects of medicine, it's a lot of learning the lingo. So it's extracorporeal membrane oxygenation. And what is it? Well, it's taking out venous blood and removing the carbon dioxide and putting in some oxygen and returning it to the patient. The premise is quite simple. You take the blood out of the patient using a pump, you put it through an oxygenator, and then you return it to the patient. The one aspect just to be aware of is that the pump, because it's centrifugal, does not always correlate directly with the flow rate. There are other factors influencing the flow, so you need a separate flow probe to measure how fast the blood is flowing, independent of the pump speed. And as a technology, it's very good for changing saturations. And you'll see many pictures of patients walking around on ECMO. This has not been our experience of how sick these patients are, where oxygen consumption is the primary problem. But when it comes down to CO2 clearance, it's actually quite effective, and you can sometimes mobilize your patients on ECMO. They don't show you the 15 people in the background making sure that this doesn't fall out while the patient mobilizes. The first ECMO successes were reported in 1971 in adults, and this is a picture of that contraption. And you can see the massive oxygenator. And actually what's happened over time is that technology has become much more friendly in terms of user friendliness and much more compact. And essentially what you get in your oxygenator is a place for water to go through, and water is just a way to regulate the temperature of the patient, so you can exactly control the temperature of the patient, because obviously if you're taking out a lot of blood at high rates and returning it, you cool down the patient quite dramatically. And then there's gas flowing through, and then there's blood flowing through. So there's a picture of an oxygenator, and there's some cannulas, because obviously you have to take the blood out somehow, so you use these big cannulas to do that. And then this is the setup that we use currently, which is a CardioHelp machine from McKay. And then you can see that the red part is the oxygenator in this setup, and then we've got a return cannula in this picture, which is the short red one, and then the longer blue one is the venous drainage cannula. And this is a picture of our first ECMO patient with a balloon pump also, and you can see that they're not mobilizing just yet. So just in terms of some context, so the technology of putting oxygen in the blood and removing carbon dioxide, that's been possible since the 1950s. 1970s were the first successes, and the oxygenators have become much, much better in terms of their interaction with the coagulation surface and their size. But in 1979, there was an NIH study that showed worse outcomes than ventilation alone. Obviously, you're taking patients with ARDS and you're wondering what is the best modality to support them with. And back in 1979, it was shown that it didn't make a difference. That's not to say people didn't try develop the technology further. And in 1989, ELSO was formed, which is the Extracorporeal Life Support Organization. And it runs a registry to which we contribute in terms of keeping track of all the different modalities, of which ECMO is one. And then in 1996, there was a UK trial that showed a survival benefit in neonates. And this was followed through 10 years later with the CESAR trial, which came from Leicester in the UK, which showed benefit for VV ECMO in adults with respiratory failure. But we'll interrogate that trial a little bit more in more detail, because when you do get asked questions potentially in your finals, you may need to give a bit more of a nuanced comment on this trial, because it's not as clear a slam dunk as it's reported in this statement. And following on CESAR trial in 2010 and 2011, the H1N1 pandemic showed numerous case control studies showing benefit of ECMO. In 2018, the French ran the Eolia trial, and it again came down as equivocal in terms of whether ECMO was able to make a difference. And the trial was actually stopped earlier because it wasn't going to prove a statistically significant difference. And there were reasons for that in the study design as well. So you just do need to understand, why is it different to bypass? Well, typically most bypasses were running roller pumps with a lot of red blood cell trauma as they compress the circuit. So these run as centrifugal pumps. There's no reservoir. It's a completely closed system. And there's no blood-air interaction, so there's less anticoagulation required. So on bypass, you need a much higher level because there's this big reservoir which interacts with air and promotes a whole coagulation cascade. In terms of centrifugal pumps, you need to understand that it's an impeller spinning, which creates the vortex that sucks in the fluid and then pushes it out. So it's non-occlusive, so it's afterload and preload sensitive, and it could, in theory, even flow backwards, even though the pump is spinning in another direction. If there's another force pushing the blood in the opposite direction, it could overcome that centrifugal pump. So you can have a pump that's spinning at 5,000 revs a minute, and the whole thing could be kinked or clamped, and then you're not going to get any flow, and the pump is just going to happily keep spinning. It's not going to build up pressure and burst it anyway. And the machine's actually quite simple at its core. There's two variables you can change. So you can change the rate of gas flowing through the oxygenator. That's called the sweep flow gas. And changing that rate alters the CO2 levels. Typically, we leave it quite low, 2 to 6 liters per minute. And just bear in mind, when you put a patient onto ECMO, you can dramatically alter the pH. So if you've got somebody who's an asthmatic with a CO2 of 20 and a pH of 6.8, you pop them on ECMO, you can really shift that CO2 very rapidly, and you actually need to be quite cautious with how you do that. As long as sweep gas is flowing through the oxygenator at about 1 liter a minute, it will not affect oxygenation. So you don't increase the oxygen delivery by the ECMO machine if you increase the oxygen flow rate from 2 liters to 6 liters. And that's an important concept to understand. It doesn't alter the oxygenation, it just alters the CO2 clearance. And if you crank it up to 10 or 15 liters a minute, it can be too high, and you could put bubbles into the blood by doing that. And then the other variable that you can change is the speed of the pump spinning, and hopefully that would alter the flow rate. And that's the speed of the blood flowing through the oxygenator. And if you put more blood through the oxygenator, you improve the oxygenation. Okay. That's often limited by the size of the cannulas you've got and the volume status of the patient potentially. So what's the catch with ECMO? Well, there's no really robust evidence to support that it makes a big difference. Okay, it's expensive and it's complicated and carries very definite risks. You have to anticoagulate your patient if you're going to run it long term, and that carries risks, and there's risks to these big cannulas going into patients as well. So let's just discuss the evidence. So the CESAR trial, which is actually not a badly named trial in terms of forcing the acronym from it, and it looked at conventional ventilation or ECMO for severe adult respiratory failure. And they showed a 67% survival versus a 43% survival, and they have a nice graph to show you the difference. But the reality is, in this trial, you were randomized to potentially be transferred to Leicester or to just receive conventional management, which may have left you at your referring hospital. And if you look at the difference between the 90 patients in each arm of this trial, 22 of those who were considered to receive ECMO, 22 of them didn't out of the 90. So 16 improved with conventional management, 3 died within 48 hours before the transfer, 2 died during transfer, and 1 had a contraindication to heparin. Okay, so if you analyze the difference, it's about 22 patients between the 2 arms. So the authors did write their conclusion very appropriately, and they said referral to an ECMO center offers a significant survival benefit for adults with severe but potentially reversible respiratory failure. And their enrollment criteria was a Murray score of more than 3 or a pH of less than 7.2 on optimum conventional management. And so I think it's important to realize that ECMO sits at the top of this very big pyramid. It isn't given to all patients, but actually, if you want to refer a patient to an ECMO center, you really have to have your ducks in a row in terms of how you're ventilating them. Are you doing all the other basics really well before you actually consider implementing ECMO for a patient? Just in terms of the ELSA registry, this just gives you an idea of the number of patients that have been supported. Okay, so it's about 25,000 for adult in terms of pulmonary and cardiac supports, and we'll discuss the difference between VV and VA ECMO. And you can see historically that after the CESAR trial, the number of ECMO centers really did increase around the world. What I do want to show you on this is obviously the outcomes in terms of survive to discharge or transfer, which is the outcome measure recorded by ELSA. It's better the younger you are in terms of neonatal, do better than pediatric, do better than adults. And it's also much more likely to have a good outcome if you use it in a VV configuration for pulmonary support, as it is to the cardiac support, as it is to eCPR. And eCPR is when you are doing CPR and you have reached a point where you would probably call off CPR, or you don't think you're getting any response, and then you actually put the patient onto an ECMO circuit and support them for a couple of days longer to see whether you can get any return of the cardiac function. We don't offer eCPR in our hospital. There are logistics and timing constraints that obviously impact dramatically on the outcome. And in this registry, you can see that they don't report what the quality of life is in terms of the survivors getting out of hospital and what condition they are. Just in terms of the cost, so you have some sort of idea, it's not terribly expensive compared to all the other things in medicine. So, 2 weeks of micafungin is probably the same cost as an oxygenator. So the machine is about R1 million. The consumables in terms of the cannulas, depending on whether you're using a heparin bonded circuit, vary from about 5,000 Rand to up to 50,000 Rand. And the oxygenator and circuit are anywhere between 50 and 78,000 Rand. Our tender initially, when we started, was to buy 5 circuits, and we got 4 additional circuits, and we had the machine placed. And we've currently got a new tender, and we can actually have 2 machines on site with 2 backup machines in case a machine fails. And we can go up to 20 circuits in a year, but typical years around about 10 patients that we would support with ECMO. The other costs, just to be aware of, is the use of an ICU bed, because we turn away patients because of ICU being at capacity. And ECMO does occupy a bed, and the patients do stay longer than a normal patient. Staffing is not a cost in our setup because we've trained ECMO specialist nurses and don't supply an extra perfusionist by the bedside or a second nurse, as some centers do. Blood products, depending on your configuration, can add up in terms of cost. The laboratory tests in terms of tags, and if you're going to dabble in fancy pharmacy medications, there's also a cost with that. In terms of how complicated it is, the nurses all do a training quiz, and this is one of the questions. If the machine is flowing at 5 liters a minute and there's an accidental disconnect, the patient's entire blood volume will be on the floor in 1 minute. True or false? So this is why a lot of our training actually focuses on the nurses and not the registrars, because if there is a crisis, there is not much time to respond to these very sick patients. It's complicated, especially if it's post-cardiac surgery. And here you can see a child with an open sternum and cannulas coming out of it. And underneath that vac dressing, it also can be quite complicated. So you can see in this configuration, there's a left ventricle vent, a left atrial vent, and there's a bicable venous cannula, and the return cannula is actually sitting in the aorta. VV ECMO as a configuration is much more simple. There's less bleeding, and basically you need to meet 60% of the cardiac output with flows on ECMO in order to oxygenate a patient effectively. Cannulation can be a challenge. Here you can see it's a difficult cut down into the neck of a child. And the reason the cannulations are a problem is that you need to put in big pipes in order to be able to flow fast enough. And we said already that the flow rate of blood through the oxygenator is the rate limiting step to how well you can oxygenate a patient. And flow is really dependent on the diameter or the radius of the cannulas that you put in. And you really want to try and use as big a cannula as possible to optimize the flows that you can get. And here you can see some cannulas. Bear in mind, some of them are marked to the tip and some of them aren't, and have variations on the number of side holes. About 70% of flow comes through the proximal side hole and not through the tip of the cannula, which is important to realize when you're placing the cannulas. In terms of sizing, we would use ultrasound to assess the size of the vessel and generally aim for 3 times the vessel size in millimeters would be the size French cannula we can get in. So if you have a 11 millimeter IJ, you can get a 31 French Avalon cannula in if you wanted to. And this is the kind of size that we're talking about. For a big adult male, we would be aiming to put a 28 French into the groin and advance that up just into the IVC where it's entering into the heart. Here's a little slide showing you peripheral VA ECMO configuration. And in peripheral VA ECMO, so on veno-venous, you're obviously draining from the venous side and returning back into the venous side. And then the job of the lungs is already done, but the heart still has to pump it through the lungs and get it around the rest of the body. In VA ECMO, you bypass the heart and you actually return it into the arterial system. And there are various configurations you can use. With the peripheral VA ECMO, you need to bear in mind that you have to have a little bit of a mind shift in terms of you can end up with a Harlequin syndrome. And this is if the lungs aren't working as well. So you're flowing back up the femoral artery. And if you only flow halfway up, because the heart is still trying to beat in these cases, you may end up with a patient who oxygenates the lower half of their body and not the top half. And on the diagram to the right there, you can also see if you've got it halfway around the aortic arch, you may only oxygenate one carotid vessel and not the other one. So it's quite important to realize that if you're doing peripheral VA ECMO, you need to be sampling your blood gas from the right arm, because that would at least be reflecting the quality of the blood that's getting to the brain. We would use NIRS monitoring as well to monitor cerebral saturation on the hemispheres as well in these patients. So you can actually cannulate on the right axillary artery as well. That's also an option. And then that would actually be forward flowing. And if we have central cannulation post cardiac surgery, like you saw in that that slide of the child, if it's sitting in the aorta, that's also forward flow. And then the sampling issue isn't such a problem. It would still reflect no matter where you're sampling. The one thing you do need to bear in mind with peripheral cannulation sites is the distal limb, because you're flowing up the femoral artery, what's going down that femoral artery, because you're already compromising the flow to it. So typically you could either use a side-biting graft and then you transfuse on the graft and you can control how much blood goes down the limb and how much goes in the other direction. Or you can use a sheath or a CVP to steal a little bit of blood from the ECMO and put it in the direction down to the foot. So it's quite important to have continuous monitoring on the limb so that you don't end up with a patient who's one limb short at the end of their successful ECMO run. So here you can see those configurations there. And then just remember, in the children, because they haven't been walking and their femoral arteries aren't big enough for these cannulas, they actually end up ligating off a carotid artery and returning down a carotid artery. And then that can't be squirting directly on the aortic valve, because you do still need the heart to eject. Otherwise, you could end up with a clotted heart. And then the other thing to bear in mind is for pleural effusions and for pneumothoraces, if you're not ventilating the patient and there's no hemodynamic problem and you're replacing the lung function with the ECMO, you don't need to put in a chest drain for these patients, okay? And you would rather wait this out. We have been burnt by putting in chest drains and been dealing with bleeding complications while the patients are on heparin, and then you just convert one problem into a massive problem, which is a recurrent hemothorax. So just bear in mind that you don't have to jump to react to an X-ray such as this when you're on ECMO. The other thing that's really important in our context is that ECMO is not a treatment. It buys you time for the underlying condition to resolve. And we're not using ECMO typically as a bridge to transplantation, and would reserve it for patients where we think that the lungs have an inherent ability to recover. Now, the catch is you need to choose your patients just right. If they're too far into multi-organ failure, you're going to have terrible outcomes. If they actually don't need it, then that's cheating, in my opinion. And you need to ensure that the patients that are getting on ECMO are just the right type of patients. In terms of TOE, just for the anaesthetists, we do use TOE a lot, and it's important in the setup not to get distracted by the TOE focus, because there's a very sick patient, and I always try and task someone to actually focus purely on keeping the patient alive during the ECMO initiation process, and deliberately not look at the TOE discussions that are going on. We would use TOE to confirm wire placement, the depth of the cannula, and in an Avalon cannula, which is like a big vas cath that you put through the IJ, with a return and a drainage limb, the orientation of that cannula is important. It also has a role in determining whether cardiovascular failure is potentially on the basis of pulmonary hypertension, or whether it's frank septic shock. Because if it's pulmonary hypertension and we fix the oxygenation CO2 problem, we can potentially have a much happier heart very quickly. Whereas if it's septic shock, you actually would need to be considering a VA configuration and rediscussing your indication, because if your patient's overtly dying from sepsis, that's not a very, it's not an outcome that normally ends very well if you've got to the point of needing to be considered for ECMO support. TOE can also assess volume status and cannula malposition if they start to move. We would use it to monitor the heart's recovery if it's a VA ECMO case, and also it will help you with your weaning strategy as well. We use it directly for making weaning assessments. This is just to show you the cannulas, and you dilate up, and we would use a Seldinger technique over a wire and dilate up to a 28 French. So it's quite a process to dilate up, and you must make sure that you don't kink your wire at all. The wires are very long. They need to be kept in a straight line, and the tip should not advance during dilatation. And I'm sure you've all put in CVPs and pushed the dilator and the wire's gone in with it, and then when you pull out the wire, you've got a kink in the wire. And you need to avoid that from happening. So the trick is, as you push the dilator in, that you actually pull back on the wire and make sure that you're not advancing the two together and potentially kinking it. And that's also a recipe to tear the vessel with your dilator as well. So make sure that your wire is always moving smoothly in the vessels. And then we typically use a dual cannulation site of the right internal jugular and the right femoral side. This is just an X-ray to show you how some of the pumps, the cannulas can look. There's a lot of pipes going in, and this one you can actually see a malpositioned venous drainage cannula. It's coming up the IVC and it's sitting smack bang in the liver. It's taken a really sharp turn to the left. So we would like to see that the cannula has made it into the liver. I'm going to skip over these. They just show you some pictures of where the cannula can sit and how you can see it on the X-ray. There are prediction scores that you can use to assess what your outcome, your expected outcome should be of a patient. And this is a case that we discussed with our governance group. We took him to theatre for intubation and expedited placement of a ECMO cannulas. So he started out with an expected survival of around 65% if we popped him onto ECMO. However, by the time he actually got onto ECMO, and I think Dave Fredericks will remember this case because he had to do some very heavy-duty CPR during the process, he was muscularly blocked, he'd had a cardiac arrest, his CO2 was over 10, his pressures were sky high, and his predicted survival had suddenly taken a dramatic turn for the worse. He subsequently was our longest run on ECMO and has done well and has gone back to work. But it took us 45 days to recover from that. The other thing to just be aware of is if you're not maybe meeting your oxygenation requirements with ECMO is to know that your cannulas are not too close together. Because in the VV configuration, if you suck out the blood that you just returned with the machine, you're actually sucking out oxygenated blood before the heart's had a chance to take it around the body and the body use that oxygen up. And you may recirculate and your system may not be as effective. So you need a degree of separation between the cannulas. Just bearing in mind that the drainage cannula does drain from the proximal holes. So actually when we put the tips and they look a little bit too close together, that might be by design. And also that means that it's probably sitting in a bigger vessel and it won't suck in the side walls of those vessels and occlude, and you won't have to give your patient as much volume in order to maintain flows. This is just to show you the Avalon cannula, which has a drainage hole in the SVC and a drainage hole in the IVC and a return hole in the middle of the heart for the right ventricle to take it through. So it just looks like a supersized vascath. I'm going to skip this one, but this, if you want to have a look at what the problem is here, the problem is that there's no pulsatility on that A-line. So this would be a case where you need to do an echo to see what the heck has happened to this heart and why isn't it ejecting. Obviously, when you're on ECMO, you want to rest the ventilator as much as possible. You want to rest the heart as much as possible, but you do need them to keep some function ticking over. In terms of VA weaning, it's a process, and we require about an hour of time in terms of doing a TOE. And just to remember, if you have to decrease the flow rate when you're weaning off VA, and then that runs the risk of the circuit clotting, because the faster it flows, the less likely it is to clot. But if you flow very low flows for a long time, you may lose your oxygenator completely. So we would potentially give a little bolus and then wean down the support in terms of the ECMO flow rates and increase the adrenaline support. And then you would make an assessment on TOE of how well the heart is functioning and measure these type of variables in terms of saying this is a patient who could potentially be decannulated. Our indications for ECMO, typically I would like to choose younger patients because they do better. Isolated respiratory failure. We don't take patients who have ventilated more than 7 days on harmful ventilatory settings. And this is why we're not offering ECMO for a lot of the COVID patients, because they seem to deteriorate beyond the 7-day window, or we can get them there, but then they suddenly decompensate afterwards. We also use it for support for post-lung transplant. If you have primary non-function from the cold ischemic time and the reperfusion injury, transplanted lungs might not work effectively, and if you can rest them, they recover well. VA ECMO, again, I'd like to choose young patients. The cardiac surgeons tend not to operate on the youngest patients, however. Cardiac failure from myocarditis is a very good indication, and we do offer it for the cardiac surgeons for failure to wean from bypass if there's a potentially reversible cause. So we need to know that the operation is a success in terms of the coronary artery bypass graft, or that the valve was situated well and is in good function. And that potentially it's related to some issues with the cardiac preservation of the procedure, or having to go on to bypass for an excessively prolonged time. Just in terms of getting onto ECMO, we don't leave it with one person to decide, oh, this is a candidate. We actually have 6 people, and we need 3 of them to be in agreement before instituting ECMO. So there's normally there's always a robust discussion before someone gets put onto ECMO, and we review the cases to check that they were appropriate and debrief with the team. Just in terms of respiratory, patients for VV ECMO, you typically need at least 12 hours of maximum conventional therapy, which would mean you need to try recruitment maneuvers, you need to try various levels of PEEP, you need to try paralysis, and you need to try proning before you can say someone's fully exhausted all the conventional support treatments and be considered for ECMO. Our logistics, we run it in D22 ICU because that's the cardiothoracic ICU, used to be before COVID times, and they have familiarity with ventricular assist devices, balloon pumps, they have familiarity with bleeding patients. You need to monitor ACTs with continuous heparin infusion. We do offer it in E26 as well, and have transferred staff up there to look after patients who have CREs or developed CREs during their ECMO run. And then it's a nurse-driven service because there's no time to call out a clin-tech or a perfusionist on short notice for pathology, for problems with the circuit. And they are much more consistent presence. All you registrars are going to leave at 3 months. The nurses we work with for a much longer period. The average ECMO run for VA is about 3 to 5 days. And if the heart isn't beating by 3 to 5 days, you need to have a discussion about palliation, because it's very likely not to ever beat again. And also for VV ECMO, it's about 2 weeks, so 14 days. Yeah, this I've said before repeatedly. So just so you understand, the nurses do their own training course, because something can happen at any hour of the day. So if you are looking after an ECMO patient, please just ask the nurses for some advice as well. They are well trained in looking after it and can give you some valuable insights. And then it's just part of our ICU arsenal of support therapies. It's not something extra or super ordinary. And this was our first training course. And then the nurses have their own form. So if you want to have a look at the training course that they do, this would be their competency checklist in terms of what competencies you need to be able to understand on the circuit, how it's run, and how to troubleshoot problems. They also maintain their own little folder with notes. So if we ask you questions on the ward round, and the nurses are recording certain variables like the transmembrane pressure, or the delta P, which is the pressure across the membrane, because if that starts to go up, then it can potentially be a sign of the oxygenated clotting. They also run a heparin infusion from a 50 ml syringe and target an ACT target, normally between 160 and 180, as per the earlier trial. In COVIDs, we have been targeting a higher ACT of around 220, which was what everyone used to target when ECMO first started, and you were more paranoid about oxygenators clotting than you were about bleeding risks. Our current patient on ECMO has got bleeding tendencies, so we're actually deliberately targeting 160 to 180 in him. And then the nurses also have a special handover form where obviously one ECMO specialist nurse coming on shift and going off shift gives us a chance just to double check everything on the system, that all the cannulas are secure, and what are the plans in terms of going forward with the patient. Just to say thank you to Temba, the Clintech, who helps us greatly with all the training. We normally do a monthly sort of wet lab, but we haven't been doing that through COVID times. Sister Jenny and Aletta for all the training of the ECMO specialists, Ingrid who does all the printing for that. Greg Caligara and Tim Pennell got this started by asking for a machine to support the lung transplant program. And then the companies that actually gave us machines and placed machines, Tower Medical and Getting, have really supported us through this. Cool. Are there any questions?
If you said that the people who get ECMO, they mustn't be too sick, but they mustn't be too well, I mean, how do you pick those people? Because like my 10 cents is that surely if you're sick enough to need ECMO, you're very, very sick, and your chances of survival aren't fantastic. So things like the Caesar trial and the Elolia trial, I mean, were they comparing apples and apples? Because if you just offer conventional ventilation to someone who could potentially survive, and you offer ECMO to people who probably will not survive, that doesn't seem very fair, if that makes sense. I mean, how do you choose someone who's not too sick but not too well?
So ideally, you'd want someone who's at risk of going into multi-organ failure, primarily from a respiratory or a cardiac point of view. So ideally, you'd want to choose patients with extreme single organ failure. And then by putting them onto ECMO, you prevent them going into multi-organ failure. So you need to get them at just the right time. In terms of assessing outcomes, so the ELSA registry doesn't really keep score of precisely how sick patients are who are getting enrolled. So that's the same as how you want to keep score between different ICUs. An ICU may have exceptional outcomes for COVID, but not actually be admitting the sickest patients. So you really do need to, if you want to keep score between things, measure precisely how sick people are who get the ICU support or the ECMO support. That is done in those trials. So Caesar trial and the earlier trial controlled well for that. The criticism of Caesar trial was that the conventional management arm wasn't well standardized. So that's why potentially Leicester, with the 16 patients who recovered without needing ECMO, was doing conventional ICU support better than some of the referral centers, where the patients were left if they were randomized to continue conventional therapy. And then Eolia did a very good job of controlling that arm in terms of the patients enrolled. It enrolled patients very quickly, so within potentially even 6 hours of presenting with respiratory failure. It controlled well in terms of the percentage of patients who were being proned and paralyzed and having a full exploration of conventional therapy before. The reason that its results are clouded is that patients were allowed to cross over from the conventional arm to the ECMO arm. If they sort of had an arrest, they could get put onto VA ECMO and be attempted to be rescued that way. So there was a crossover potential that confounded the interpretation. And also they set the bar incredibly high in terms of they wanted to prove that ECMO made at least a 20% difference in mortality, and they weren't going to prove that degree of difference, and that's why that trial was started early. So they set the bar incredibly high for ECMO as a single intervention to make a difference in ICU, which is normally a very heterogeneous group. So the Eolia trial confirms your belief if you think conventional is fine, or it could confirm your belief if you think ECMO is definitely got a place. Yeah, I hope that answers your question.
Cool. Yeah, thanks very much. Thanks.
Cool.
I want to find out, what are your endpoints when you're caring for your patients on ECMO? And sometimes do you do renal replacement therapy for them?
Yeah, so we have offered renal replacement therapy. If we do it through a separate VASCATH cannula preferentially. But sometimes you run out of access sites, and you can connect a CVVHD machine onto the ECMO circuit, but that obviously runs risks of infection. You need to be able to set the alarms on the dialysis machine to tolerate the higher pressures. So we typically don't like to do that, and would dialyze someone through a vascular a vascath. Yeah, so we do support them with that. Obviously, that's in the context of what's happening. Why has this happened? Hopefully, it's an insult that is resolved, and now that the patient's stable on ECMO, that it doesn't progress, and they could have recovery of renal function. And we have had survivors through that. So we would add an additional organ support, but we wouldn't typically take people with traumatic renal impairment already. That for me would be a sign that there's a multi-organ failure setting into this patient, and at your timing, you've maybe missed the window already. Any other queries?
And what are your endpoints when you're taking care of a patient on ECMO?
So it's nice to try and get normal endpoints, but again, we've found that targeting normality in ICU when you're trying to get people through, you sometimes cause more harm than good. So flowing at very high flow rates causes hemolysis, and you can end up with problems related to that. So typically we would want SATs of 85% or higher, a normal lactate, and no signs of worsening organ dysfunction. And we would feel completely comfortable with that. CO2 is generally no longer a problem, and you can just increase the sweet flow as required. And the nurses actually flush the oxygenator, just blast it with a bit of high flow for sort of 10, 15 seconds to remove the condensates, which is sometimes why you see the CO2 creep on these patients the longer you go into your run. So again, the same targets that we would target for ventilation when we're battling in these patients. And then what target do you set the ventilator at? There's quite a lot of debate in the literature. So should you just switch off the ventilator and extubate the patient? Should you keep a tidal volume of 4 mils per kilo? Should you keep it a little bit closer to normal? Our feeling would be to go down probably to a respiratory rate of around about 12, a driving pressure of 12, and to maintain a slightly higher PEEP so that you don't end up with completely collapsed lungs that you're going to struggle to re-expand at some point. So we'd probably set everything pretty much at 12 and an FiO2 level of 60% or less. We are kind of leaving it 60% and not turning it down to 21%. Typically, we find that the patients do need some lung function, and they do use that a little bit. So there's quite often a balance between the ECMO and ventilation. Our current patient is not ventilating at all and is solely dependent on the ECMO circuit at the moment.
In VV ECMO, you said that you're supporting the pulmonary function, so the heart is being used to pump the blood. So for those lungs, do things like hypoxic pulmonary vasoconstriction, can that cause a problem for the ECMO? How would you overcome that? And if you had pulmonary hypertension, would that cause problems for ECMO? Because the heart is normal, but it's trying to pump against this increased pressure.
So that's why I said there's quite often you need to assess whether it's more pulmonary hypertension or whether it's frank septic shock in these patients. Because if you fix the hypoxic vasoconstriction, you quite often ease the burden on the heart, and the heart does much better and quite quickly too. So it is definitely a factor. What we also find is you'll initiate ECMO and get very nice numbers initially, and you'll see that it gradually changes over time. And that might be related to those hemodynamic changes in terms of what's going through the heart and that matching. Yeah, so it's once you put a patient on ECMO, it's not just plug and play and walk away and everything will be as perfect as it was running right at the start. Settling the patient in over a couple of hours is quite a real process for these patients.